Very warm good morning to everyone. I welcome you all to the ENT seminar. Today, me and my colleagues from roll number 76 to 90 is going to present a case of ear and related theory. My name is Prakash Kumar, roll number 86. I am presenting the case of Ramesh Kumar, a 20 years old man residing in Andheri. He presented to the OPD on the 24th of January with a primary concern regarding the right ear. The patient reports a continuous, non-bloody mucopurulent discharge from the right ear lasting 8 months. Notably, the discharge is foul-smelling and accompanied by a subjective decrease in hearing. Significantly, he has a history of recurrent ear and upper respiratory tract infection, but denies any history of trauma, vertigo, or facial asymmetry. On general examination, the patient appears undernourished but remains hemodynamically stable. Local otoscopic examination of the right ear reveals a central perforation with active mucopurulent discharge. The left ear was examined and found to be normal. Investigations were carried out to quantify the deficit and identify the pathogen. Pure tone audiometry confirmed a conductive hearing loss in the range of 30 to 40 decibels, and ear swab culture grew Pseudomonas aeruginosa. Finally, imaging of the mastoid is here. You can see finally imaging of the mastoid shows sclerotic changes and a radiolucent shadow on the right side as seen. Instead of the honeycomb appearance of a normal pneumatic mastoid, like you might see on the left here, you can see very clear mesh-like structure, mesh-like mastoid, but on the right side it is very whitey appearance. Thank you. Now I would like to call upon my next colleague, Omkar Khatke, to explain the anatomy of ear.
Roll number 78. My topic is anatomy of ear. So, the ear is the characteristic vertebrate organ of hearing and equilibrium, consisting of the typical mammal of a sound collecting outer ear, a sound transmitting middle ear, and a sensory inner ear. In simple words, it is an organ of hearing, and it also plays a key role in the equilibrium of the body. It is divided into three fundamental structures: the external ear, middle ear, and internal ear. So the anatomy of the external ear, it consists of the three parts: the auricle, the external acoustic meatus, and the tympanic membrane. So here we can see the outer ear. It extends from the pinna to the tympanic membrane. So the first auricle, pinna. The auricle is a cartilaginous or cartilaginous structure, mainly composed of the elastic cartilage, except the lobule, which consists of the fats and the fibrous tissue. It has some important clinical features like the helix, antihelix, tragus, antitragus, the scaphoid fossa, and the concha, the deepest part leading into the ear canal. Its functions is it collects the sound waves and it funnels it into the ear canal. It also functions as the sound localization, like to detect the direction of the sound from where it's come. Here is a diagram of the auricle. Here we can see the outer ring, the helix, we can see the outer rim of the helix. There is a small projection above the external canal, the tragus, and just opposite it there is the antitragus part. And just above we can see a ridge part, a curved ridge, which is the antihelix. The downward we can see a lobule, and here we can see the scaphoid fossa. And we can also identify the concha region, which will lead into the ear canal. The next part is the external acoustic meatus. It is approximately 2.5 centimeter long and extends from the concha to the tympanic membrane. It has actually two parts: the lateral 1/3, which is cartilaginous, and the medial 2/3, which is bony. The cartilaginous part contains the hair follicles, the sebaceous gland, and the cereminous glands. The inner 2/3, the bony part, is narrower and more sensitive, and the cereminous glands secrete the ceremins, which is the earwax, and it functions as trapping the microorganisms or the dust particles and prevents the external bodies entering. The function is it conducts sound and provides protection. Here we can see the diagram. Where the first 1/3 part is the cartilaginous and the medial 2/3 is the bony. The third part is the tympanic membrane. It's a thin oval shaped transparent membrane separating the external and the middle ear. Its important features are the pars tensa and pars flaccida. The pars tensa, as its name, it's the main part and more tense, while the pars flaccida is a smaller part. Its function is it converts sound waves into the mechanical vibrations. Here we can see the diagram of the tympanic membrane, where we can see the pars tensa, which is covering almost 90% of the tympanic membrane, and above there we can see the pars flaccida. There we can also see the malleus hand under the malleus, or the manubrium of the malleus, which creating a depression which we call the umbu. Below the umbu we can also see the cone of light, which is usually seen during the otoscopic examinations. It has a clinical importance, as it indicates the normal tympanic membrane. There are usually 3 layers in the tympanic membrane: the outer, middle, and the internal. The outer is made up of the cuticle layer. The middle is made up of the fibrous layer. The fibrous layer is usually majorly in the pars tensa. The pars flaccida has the alveolar tissues. The middle layer is also divided into 2 parts: the superficial and deep. The superficial has the radial fibers, and the deep parts has the circular fibers, which are more dense in the periphery. And by here, I conclude the external layer by the external layer plays a vital role in conducting, amplifying, and collecting the sound, and it also protects the inner parts of the ear. Thank you. I would like.
Good afternoon, everyone. Myself Pratik Ganesh Budwar, and I am here to represent anatomy of middle ear. Firstly, to simply understand the anatomy of middle ear, we can say it is like a cube which is having 6 walls, and it is air filled with mucous membrane lining it. The main function of the middle ear is it acts as an impeding matching mechanism. It transfers the acoustic energy of sound waves in air into mechanical vibrations in the fluid of the inner ear, amplifying the force. This is the simple diagram of ear. Here we can see that middle ear, on the medial side, it is on the medial side there is a medial wall which separates the middle ear from the internal ear, and on the lateral side there is a tympanic membrane which separates the middle ear from the external ear. Now we will discuss about the medial wall of the middle ear. On the medial wall of the middle ear there is presence of the promontory. This is the promontory. On the promontory there is a tympanic plexus which is formed by the Jacobson's nerve, which is a branch of glossopharyngeal nerve, the ninth cranial nerve, and the sympathetic plexus and the sympathetic plexus from which is bound to the internal carotid artery. Then we can see on the superior or posterior side of the promontory there is oval window where there is attachment of the stapes bone is present. On the here is the oval window. On the posterior inferior side of the promontory there is the round window where the attachment of secondary tympanic membrane is present. On the superior side of the oval window we can also see the facial canal impression and the lateral semicircular canal impression. Now we will discuss about the lateral wall of the middle ear. On the lateral wall of middle ear there is presence of the tympanic membrane and the attachment of the ear ossicles, lateral medius. Now we will discuss about the floor of the middle ear. In the floor of the middle ear, it is separated by a bone which separates it from the tubule of the internal jugular vein. There is also Jacobson's nerve which pierces from the base floor of the middle ear, which is Jacobson's nerve, which is a branch of glossopharyngeal nerve which form the tympanic plexus on the promontory. Now we will discuss about the roof of the middle ear. The roof of middle ear have the roof of the middle ear is having the bone which separates the middle ear from the cranial fossa. Now we will talk about the anterior wall of the middle ear. On the anterior wall of the middle ear, we have the tubal opening which is for the auditory canal or eustachian tube. We also have a process cochleaformis which act as a pulley for the tensor tympani muscle. On the posterior wall, we have adductus antrum which communicates with the antrums air cells on the posterior side of the middle ear. Now we will discuss about the content of the middle ear. The middle ear contains three ossicles, two muscles which are tensor tympani and stapedius, and two nerves, chordae tympani and tympanic plexus. And there is also presence of ligaments. As we can see here, these are the ossicles and the ligaments. The chordae tympani arises from the posterior wall of the middle ear, which is the branch of the facial nerve. Thank you. I will ask Bhavesh Patil to continue.
Good afternoon everyone, myself Bhavesh Patil, roll number 18. I will be presenting seminar on topic internal ear, anatomy of internal ear. So inner ear, also known as labyrinth, is present on petrous part of the temporal bone, and It consists of bony labyrinth within which there is a membranous labyrinth, and the function of internal ear are hearing and balance. So we will now talk about bony labyrinth. So it is a rigid cavity temporal bone containing perileaf, and it has three parts. Anteriorly cochlea, in the middle there is a vestibule, and posteriorly semicircular canal. So cochlea, it is a spiral-shaped structure around the central axis known as modulus, and it is divided into three parts: scala vestibuli, scala media, and scala tympani. Scala vestibuli and scala tympani contain perileaf, and scala media contain endoleaf. And the function of cochlea is hearing. Vestibule, it is a central part of a bony labyrinth, and it is connected anterior to the cochlea and posteriorly to the semicircular canal. And it has two structures, utricle and saccule, which are important for static equilibrium. The semicircular canal, which is the most posterior-most part of bony labyrinth. There are three canals: anterior, posterior, and lateral, and they are arranged in right angle to each other, and each has ampulla. And the function is dynamic equilibrium, especially the rotatory movement. And organ of corti, which is present in cochlear duct, and it is a sensory organ for hearing. Thank you. Now we have to other discussion.
Good afternoon, everyone. Myself roll number 90. Today I am here to talk about blood supply of the ear. Let's start with the atrial supply first. For the external ear, it is supplied by the branches of external carotid artery. Outer part is mainly supplied by the superficial temporal artery. As you can see here, and the posterior auricular artery. Inner part is mainly supplied by the deep branches of the deep auricular branches of the maxillary artery. Middle ear, which has a rich and a complex blood supply, supplied by the branches of the maxillary artery, which is anterior tympanic artery. Here you can see, and the ascending pharyngeal artery, and the middle meningeal artery. This artery forms a vascular network around the tympanic cavity, which is important to maintain the health of the middle ear structure. Inner ear, which is also known as labyrinth, have a delicate blood supply. It is supplied by the labyrinthine artery, which is a branch of anterior inferior cerebellar artery. Now let's see the venous drainage. For the external ear, it drains into the superficial temporal vein and the posterior auricular vein. This vein ultimately drains into the external jugular vein. Middle ear, waste from the middle ear drains into the superior petrosal sinus and the pterygoid plexus of the veins. And finally, the inner ear, which is drained by the labyrinthine vein. This vein drains into the superior or the inferior petrosal sinus. Thank you. Now I would like to call Purnima to continue further.
Good afternoon to all. Myself Purnima Pawar, my roll number is 82. Now I will discuss the nerve supply of ear. So as we know, the ear is divided into external ear, middle ear and inner ear. Each part has a distinct nerve supply. This nerve supply includes the cranial nerves and cervical nerves. This is very important clinically for diagnosing ear pain and various nerve lesions. So let us start from external ear. external ear contains auricle and external auditory canal. Auricle is supplied by great auricular nerve, lesser occipital nerve, and auricular temporal nerve. The great auricular nerve and lesser occipital nerve are cervical nerves, and auricular temporal nerve is a branch of trigeminal nerve, which is cranial nerve. External auditory canal is supplied by auricular temporal nerve and auricular branch of vagus nerve, which is also known as Arnold's nerve. Arnold's nerve, the supply of Arnold's nerve also explains the Arnold's reflex, which is when we stimulate the external auditory canal, there is cupping reflex. It is due to as Arnold nerve supplies various other respiratory parts and parts of larynx, so we get Arnold's reflex. So as we can see in the diagram, supply of auricle and supply of tympanic membrane with external auditory canal. Now middle ear. The middle ear is mostly supplied by tympanic plexus, which is formed by a branch of glossopharyngeal nerve and sympathetic fibers, which arise from sympathetic plexus around internal carotid artery. This supplies middle ear cavity, eustachian tube, and mastoid ear cells. So as we can see in the diagram, the blue nerve that is coming is a glossopharyngeal nerve. The yellow colored nerve are the sympathetic fibers arising from around the internal carotid artery. These form a tympanic plexus at the promontory region and supply mastoid ear cells, mucosal layer, and eustachian tube. Now let us discuss the nerve supply of inner ear. Inner ear is supplied by the vestibulocochlear nerve, which is also known as 8th cranial nerve. It has two components. We have cochlear nerve and vestibular nerve. Cochlear nerve functions of hearing, and vestibular nerve does the function of balance. Let us see through the diagram. So here we can see the blue division is vestibular nerve division, and yellow colored is cochlear nerve. Vestibular division goes to scapus ganglion, and from there it supplies various parts: cristae, maculae, utricle, and sacules. And yellow division is cochlear division, which goes to spiral ganglion and supplies cochlea, organ of cochlea, and detects sound. Thank you. Now I would like to call Prachi for the topic.
Hello everyone, I am Prachi Rahamdale, roll number 85. So I am going to discuss the auditory pathway, the route by which the sound travels from our ear to the brain. So here is an animated video. You can see first. The auricle collects the sound waves, and via the external auditory meatus it comes to the tympanic membrane, and it causes a vibration in the tympanic membrane along with the ear ossicles and the cochlea. Then due to the vibration of these sound waves are converted into the nerve impulses, and then the nerve impulses are picked up by the auditory nerve, which is also known as the cochlear nerve, which then sends it to the midbrain, brainstem, and here the first station in the brainstem is the cochlear nucleus, which interprets this sound, and after processing it, it sends it to both the sides of the brain via the auditory stria, which are of the three types: ventral, intermediate, and the dorsal. This tells us that the auditory pathway is bilateral in nature, and this crossing over of the signals helps us in the localization of the sound from where it is coming from, and then the signals goes to the superior olivary nucleus, which plays a key role in detecting and differentiating the different sounds reaching our different ears. And nextly, the signals ascend upward with the help of the lateral lemniscus to reach the inferior colliculus. And inferior colliculus is the part of the midbrain which is responsible for the reflex response, like turning our head when we hear a sudden noise. And then the signal goes to the medial geniculate body of the thalamus, which act as a relay station of the signal, and directing these the medial geniculate body directs this signal into the correct area of the cortex. Finally, the signal goes to the cortex, which is the auditory cortex present in the temporal lobe. This area helps this area consciously perceive and interprets the signal which comes there, and this is how we understand the sound, different music that reaches our ear. So while in the summary of the auditory pathway, this goes as the cochlea, auditory nerve, cochlear nucleus, superior olivary nucleus, lateral lemniscus, inferior colliculus, medial geniculate body, and lastly the auditory cortex. Next, as we talked about the auditory cortex, it is divided into two: the primary auditory cortex and the secondary auditory cortex, which is also known as the association auditory cortex. So the primary auditory cortex is present in the Brodmann's area number 41 and 42 in the Hessel's gyrus, which we can see after the retraction of the lateral sulcus. And the second one is the secondary auditory cortex, which act as the association area, as we know, and it is primarily present in the area number 22 in the superior temporal gyrus of the temporal lobe. So thank you, and now I would like to call the Pratmesh to explain about the development.
Good afternoon everyone, I am Pratmesh Potpalya, roll number 84. Today I will be presenting the development of middle ear. This topic is important to understand both the anatomy and clinical conditions related to hearing. So the middle ear primarily develops from the first pharyngeal membrane, which is endodermal in origin. And so it forms a structure called the tubotympanic recess. The otic capsule shown here forms indicates the developing which is ectodermal in origin. The first pharyngeal pouch develops the external ear canal, and the second pharyngeal pouch, which is shown here, is just for orientation but does not contribute here. Now the tubotympanic recess, the proximal part of the tubotympanic recess forms the auditory tube or the eustachian tube, and the distal part develops the tympanic cavity. The junction of endoderm, that is pouch, ectoderm, that is cleft, and mesoderm forms the tympanic membrane. Now the tympanic cavity is initially mesenchyme filled, which later gets resorbed and which is later filled by air. The ear ossicles. The three ear ossicles are developed from the pharyngeal arch cartilages. The malleus and incus are developed from the Meckel's cartilage of the first arch, and the stapes is developed from the Reichert's cartilage of the second arch. These three ossicles are initially embedded in mesenchyme, which later become free in the forming middle ear cavity. They are now covered by the endodermal epithelium. The tympanic membrane. The tympanic membrane is derived from the first pharyngeal membrane. It has three layers: the outer ectodermal layer, a middle mesodermal layer, and an inner endodermal layer. This trilamic structure is important for its function in sound transmission. There are two important muscles in middle ear: the tensor tympani. The tensor tympani muscle is developed from the first arch and is supplied by the mandibular nerve. And the stapedius muscle is developed from the second arch and is supplied by the facial nerve. Now my colleague Vibhor will explain the
Go one slide back.
लेबलिंग गलत
ये लेबलिंग तो एक्टोडर्म
एक्सटर्नल अकोस्टिक
एक जगह पे ना एंडोडर्म चाहिए था देखो
अंदर भी और बाहर भी एक्टोडर्म है।
दोनों तरफ एक्टोडर्म
वो ब्लू वाला है ना वो एंडोडर्म चाहिए। ओके ठीक है।
Now my colleague Vibhor will explain the applied anatomy. Thank you.
Good afternoon everyone. My name is Vibhor Pawar, roll number 83. I will be explaining the topic applied anatomy of middle ear. Autosclerosis. Autosclerosis is the bony fusion between the foot of stapes and the margin of oval window. It may lead to deafness. It can be corrected by the if the prosthesis is put in place and the deafness could be cured. And second, basalt abscess. Basalt abscess is a subperiosteal post-auricular abscess. The spread of infection may be spread due to the infection of mastocytitis. As you can see in this image, in the post-auricular region of this girl, basalt abscess is there. And in the image above, the first image, you can see autosclerosis, the fusion between the foot of stapes and the oval window is there. And in the second, the corrected version is there, where the prosthesis is in place.
ते स्टार आहे ना ते स्टार त्याच्यावर हां.
Staphyloctomy. Staphyloctomy is the surgical removal of stapes in case of autosclerosis. And staphydotomy. Staphydotomy is an alternative for staphyloctomy. Instead of removing the stapes, some surgeons refix it. Third, hyperacusis. Hyperacusis, tensor tympani and staphylococcus dampen the loud sounds that come to our ear and protect the internal ear. Paralysis of these muscles can cause hyperacusis. We saw hyperacusis previously in Bell's palsy as one of the symptoms. And in hyperacusis, people develop sensitivity to sound. Otalgia. Otalgia is nothing but a fancy word for ear pain. The pain of middle ear and external ear gets. It's just a medical. It's just a medical term for ear pain. The pain of middle ear and external ear gets referred to tongue tonsils or pharynx through glossopharyngeal nerve and to teeth through mandibular nerve. Otitis media. Otitis media is a suppurative infection of the middle ear. It is common in infants and children due to their small horizontally placed auditory tube and small external ear. It can spread to the middle ear through nasopharynx from the auditory tube or from the external ear. As you can see in the diagram, the middle ear, there is inflammation and fluid accumulation in the middle ear, which has caused the eustachian tube to be narrow. The pathophysiology behind it will be explained later. Acute suppurative otitis media and chronic suppurative otitis media. In acute suppurative otitis media, rapid onset and painful infection. It is a rapid onset painful infection which is caused due to bacteria and viruses. It is characterized by redness, swelling, and fluid and pus accumulation behind the eardrum. Chronic suppurative otitis media. It is a persistent middle ear infection that causes long-term inflammation, which may result in perforation or rupture of the eardrum and continuous pus or watery drainage. Thank you. Now I would like to call Pranav Yadav for his topic pathophysiology.
A very good afternoon to one and all. My name is Pranav Yadav, roll number 87, and I will be presenting before you the pathophysiology, which will be discussed under the headings. First one, we will say transition, how the transition takes place from the acute to chronic infection. The second one, we will see eustachian tube dysfunction. The third one, that is we will see the changes that are taking place in the tympanic membrane. The fourth one, how the chronic infection establishes itself. And the lastly, we will see types of CSF. starting with how the transition from acute to chronic infection takes place. How we define chronic infection? That is, chronic infection is defined as persistent discharge which is for greater than 6 weeks to 3 months. The mechanism behind it, the chronic infection develops when acute inflammatory process fails to resolve. This is how the chronic infection develops. As we can see in acute phase, there is mucosal hyperemia and exudation. Now, what do you mean? What do you mean by hyperemia and exudation? Hyperemia means there is increased blood supply to a particular site, and exudation means there is leakage of fluid that is rich in proteins and the blood cells. Now, talking about the persistent factors, the mucosal inflammation that has been developing persists when there are 4 points. The first one, when the tympanic membrane perforates. Second one, the infection is treated inadequately, that is when the wrong antibiotics are given or there is poor compliance. The third one, the host has low resistance, that is the person is suffering from malnutrition or the person is immunodeficient. And the fourth one, there is eustachian tube dysfunction. Now moving on to the irreversible changes that are taking place, the ciliated columnar epithelium of the middle ear undergoes goblet cell hyperplasia. Now, what do you mean by hyperplasia? Hyperplasia means there is increased amount of cell production, that is particularly of the goblet cells. Function of goblet cells is to produce mucus, and this produces purulent and mucopurulent discharge, which leads to persistent chronic discharge. Now we can see the image comparisons. The first image shows the normal tympanic membrane. The second one, it is of acute suppurative otitis media, and the third one, it is of chronic suppurative otitis media. In acute one, we can't see perforation in the tympanic membrane, whereas in chronic one, we can see that perforation is taking place in chronic one. Now, moving on to the eustachian tube dysfunction. Eustachian tube is basically considered as the main culprit behind the otitis media infection. Talking about the mechanism, the function of eustachian tube is to maintain an equilibrium. That is, it maintains middle ear pressure with the atmospheric pressure. And when this eustachian tube gets blocked, it may be blocked due to the various reasons. And the reasons are adenoids, allergic rhinitis, and the chronic sinusitis. And due to this reason, when eustachian tube gets blocked, the middle ear mucosa absorbs the trapped air. This absorption creates a negative pressure or the vacuum in the middle ear space. Now, the vacuum or the negative pressure that has been created in the middle ear space, this negative pressure pulls the tympanic membrane, that is weakest part of the tympanic membrane, is being pulled inwards, that is the pars flaccida part, which creates a retraction pocket, and this pocket accumulates desquamated keratin, which is the starting point for primary acquired cholesteatoma. In this figure, we can see the retraction pocket, that is invagination of tympanic membrane is taking place inwards. Now moving on to the what are the changes that are taking place in the tympanic membrane? The membrane undergoes structural alteration due to the chronic inflammation. The membrane also undergoes perforation. There are two types of perforation. First one, central perforation, and the second one, that is attic or marginal perforation. In central perforation, there is involvement of pars tensa, but the annulus, which is the ring, it is maintained intact. And this is the hallmark of safe or the tubotympanic chronic suppurative otitis media. In attic or marginal perforation, there is involvement of pars flaccida, and there is also destruction of annulus, that is the ring, due to which we also call it as marginal perforation, which allows the outer ear skin to migrate into the middle ear, and this leads to the unsafe chronic suppurative otitis media. And there are also other structural changes that are taking place in the tympanic membrane, that are retraction pockets and tympanoclerosis. Retraction pockets, as explained earlier, it is the invagination of the tympanic membrane inwards due to the negative pressure that has been constantly created in the middle ear space. And tympanoclerosis, in tympanoclerosis there is deposition of highly or the white calcium patches in the tympanic membrane. So this is the tympanic membrane, and we can see the white calcium patches that are developed on the tympanic membrane, which is called as tympanosclerosis. Now moving on to the establishment of the chronic infection. How chronic infection establishes itself? Firstly, there is biofilm formation. The bacteria or the pyogenic organisms which invades the middle ear. Pyogenic organisms means the organism which produce mucus. That bacteria forms a protective polymeric matrix, making them highly resistant to systemic antibiotics and the host immune cells. The biofilm which is formed makes them highly resistant to systemic antibiotics and host immune cells to destroy them, and which also explains the surgical treatment that is required for the chronic suppurative otitis media. Now moving on, the second point, there is squamous metaplasia, that is the normal respiratory epithelium of the middle ear converts into the stratified squamous epithelium. Now moving on, there is osteitis and the bone dissection. Now the chronic inflammation that has been developing continuously leads to release of the osteoclast activating factors. Osteoclast means bone dissolving cells. Release of the osteoclast activating factors leading to the bone destruction and conductive hearing losses. So in this image we can see the biofilm formation, and the second part, there is osteoclast activating factors which are released by the chronic inflammation that has been continuously developing. Now moving on to the types of chronic suppurative otitis media. First one, it is tubotympanic, and second one, that is aticoantral. The first one is also called as tubotympanic or the safe type of chronic suppurative otitis media. The definition: tubotympanic disease is a chronic inflammation of the middle ear cleft that is strictly confined to the anterior inferior compartment. Now, the anterior inferior compartment includes eustachian tube, mesotympanum, and the hypotympanum. And the chronic suppurative otitis media type 1 is also called as safe because the pathological process is entirely mucosal, and it does not involve any osteitis, that is the bone destruction, and also it does not involve the formation of cholesteatoma. Therefore, the risk of serious intracranial complications like meningitis or brain abscess is exceptionally rare. If there is osteitis, there will be serious complications. In this, the serious complications are absent. Moving on to the etiology, it is more common especially in infants and the children of socio-economic groups. Now, why it is common in infants? Because we know the eustachian tube is horizontal, which leads to which is more prone to the infection, and it is common in children of lower socio-economic group because the person suffers from malnutrition, and if the acute infection develops and the person is suffering from the malnutrition, it leads to chronic inflammation. And typically the disease follows viral infection of the upper respiratory tract, but the pyogenic organism which are present in the respiratory tract soon invades the middle ear through the eustachian tube. Moving on to the pathogenesis, as explained, this disease is a typically ascending infection or sequela of an unresolved acute infection. What do you mean by sequela? Sequela means when the acute inflammatory process fails to resolve, the acute infection leads to the chronic infection. The figure showing chronic suppurative otitis media type 1, in which there is absence of osteitis and the cholesteatoma. Moving on to the type 2 chronic suppurative otitis media. The type 2 chronic suppurative otitis media is also called as aticoantral disease, which involves the posterior superior compartment. Now, what does posterior superior compartment involves? The posterior superior compartment involves the attic, antrum, and the mastoid air cell system. Now, type 2 is also called as unsafe. Why we call it as unsafe? Because the hallmark of this disease is bone destruction, that we call as osteitis, and presence of cholesteatoma or active granulations. Now, if there is bone destruction, this leads to exposure of the dura mater, lateral venous sinuses, facial nerve, making the patient highly susceptible to life-threatening intracranial and extracranial complications. If the durameter is exposed, the patient can suffer from meningitis. The patient facial is exposed. There are various complications that are the extracranial complications the person can suffer. And in this figure, we can see the attic retraction pockets that are developing in the tympanic membrane, which is caused by the negative pressure that has been continuously developing in the middle ear. Thank you.
So, good afternoon, one and all. Myself, Priyanka Patil, and I'm roll number 81. So, chronic suppurative otitis media is not just a persistent infection, but a progressive pathological disease. So, now I'll be explaining how this chronic inflammation leads to structural damage and functional impairment within the middle ear cavity. So, first and foremost, we have chronic inflammation. So, here, due to persistent infection, the middle ear mucosa undergoes chronic inflammation. This leads to mucosal edema, increased mucus secretion, and hypoplasia of the lining epithelia. Additionally, there is impairment of the ciliary function, which leads to reduced clearance of these secretions. As a result, these secretions or the infected material stays within the middle ear cavity itself, which further promotes the process of inflammation. So with the ongoing inflammation, granulation tissue develops as body's natural tissue repair response. Granulation tissue consists of proliferating capillaries, inflammatory cells, and fibroblasts. However, in case of otitis media, this process becomes disorganized and excessive. So instead of promoting wound healing, granulation tissue acts as a reservoir of infection and interferes with body's normal tissue repair. Next, we have fibrosis and tissue remodeling. So over time, this inflamed tissue becomes thick and fibrotic. This reduces the mobility and elasticity of the tympanic membrane as well as the associated structures. As a result, the normal vibratory function of the middle ear is compromised. So one of the major consequences of prolonged inflammation is damage to the ossicular chain. So inflammatory mediators and enzymatic activity cause erosion of the ossicles, especially the incus. So this disrupts the ossicular chain, which ultimately leads to impairment of sound transmission from the tympanic membrane to the inner ear cavity. Now the most significant complication of chronic suppurative otitis media is the formation of cholesteatoma. Cholesteatoma is a cystic mass which arises from the retraction pocket of the tympanic membrane due to accumulation of keratinized squamous epithelia. This lesion grows gradually and releases enzymes which cause progressive bone erosion. Due to cholesteatoma's ability to cause bone erosion, this disease is no more confined to the middle ear cavity and it may extend to the adjacent structures. One such extension is towards the intracranial cavity. So in advanced cases of otitis media, the chronic infection of the middle ear may extend intracranially either through bony erosions or through venous sinuses. As a result, the infection leads to inflammation of meninges, causing meningitis. It may also lead to thrombosis of venous sinuses. And lastly, it may also lead to accumulation of pus in the brain, forming brain abscesses, which are normally found in temporal lobe and cerebellum. So to summarize, structural changes such as inflammation, fibrosis, disruption of the ossicular chain, and formation of cholesteatoma ultimately lead to inefficient sound transmission from the inner ear to the inner ear, which ultimately manifests as conductive hearing loss. Thank you, and I'd like to call Ishan to continue further.
Good afternoon everyone, my name is Ishan Pathak, roll number 79, and today I am going to present on diagnostic criteria of acute and chronic suppurative otitis media. Now starting with the clinical findings of the acute suppurative otitis media, it is a short duration infection which lasts for typically less than 3 weeks of duration. The characteristic features are throbbing ear pain with high graded fever and sudden onset of the conductive type of hearing loss. The ear discharge is acute, painful and purulent, which is initially has blood tinge but later becomes thick and purulent. The vertigo and facial nerve palsy are rarely present. On otoscopy, tympanic membrane is seen to be reddish in color, congested, bulging outwards, and mobility is highly reduced. The perforation is temporary and usually small and centrally located with irregular and inflamed margins. The landmarks are obscured, cone of light may be either absent or distorted. Granulation and cholesteatoma is absent in acute suppurative otitis media. Now comparing with the chronic suppurative otitis media, clinically it persists for more than the duration of 6 weeks. The hallmark feature of the CSOM is recurrent or persistent discharge, which is painless, and the discharge may be is mucoid or mucopurulent in nature, and foul odor may be present in the discharge. The tinnitus is commonly reported by the patient, and vertigo and facial nerve palsy may be present. On otoscopy, the typically membrane is mostly pale in color, retracted, and the mobility is reduced depending on the fibrosis of the tympanic membrane. The perforation is permanent and may either be centrally located or marginalized. The margins of the perforation are well defined and epithelialized due to fibrosis. The landmarks are visible only if the condition is severe. The cone of light is distorted, and the cholesteatoma and granular tissue are often seen to be present in chronic suppurative otitis media. Thank you. Now I would like to call Numera for further presentation.
Good morning everyone. I am Numera Iqbaluddin, roll number 77. Today I will be discussing the signs and symptoms of this case. So as already discussed, the pathology of CSOM is related to the middle ear. And I will now briefly discuss about how it is presented in patients clinically. It is typically characterized by persistent ear discharge, hearing difficulty and tympanic membrane changes which are visible on examination. So now coming on to the symptoms, these are some brief complaints given by the patients, most common being ear discharge, which is otorrhea. It is long-standing in nature and patients often describe it as continuous or occurring in brief periods. It can be improving. It can have periods of improvement, or it can also have periods where it can digress in nature. We also have variation in the type of discharge. It can be mucoid, which is thick mucus-like, or it can be mucopurulent, which is infected pus mucus. Sometimes it can also be cold swelling, which is related to the case of cholesteatoma. Another important symptom is hearing loss. It is usually gradual in nature and it may not be detected early because particularly it can be seen only in one ear initially. And sometimes patient also report tinnitus, which is ringing of the ear, and it is intermittent in nature, and we can also feel ear fullness or discomfort in their ear. Upon examination, we can observe several things. Most importantly, tympanic membrane perforation. It is important because it is important in relation to its size and location, so we can figure out the nature of the disease and the progress of the disease. And we can also see ear discharge in the external auditory canal, and we can assess its character on examination. The middle ear mucosa can appear abnormal, can look inflamed or edematous, and sometimes we may also see granulation tissue, which is a red inflamed area which upon touching can bleed, and in advanced cases we can see oral polyp, which is a red inflamed mass present. Hearing loss is tested through tuning fork frequency test, and for example, there is one Rhine test, and then there is Weber's test, and it is confirmed on pure tone audiometry. Now there are certain clinical features which are less common, but they are important to be talked about because they can they are in close relation to the middle ear. For example, some patients may report imbalance or unsteadiness, which is related to the vestibular apparatus and the semicircular canal. Some also report altered taste sensation, which is due to the involvement of collar tympani nerve, and it is in association with the facial nerve as it runs through the middle ear cavity, medial to the tympanic membrane between the megas and incus. There is also increased sound sensitivity or altered sound perception, which is due to the defect in stapedius muscle and the innervation, which is by facial nerve. We can also appreciate the reduced mobility of the tympanic membrane upon examination. So to conclude, the clinical presentation of chronic suppurative otitis media, it is typically characterized by the findings that we have found, the findings that we have seen related to the middle ear and its close anatomical relations. While it is important to see certain clinical findings to relate and diagnose the condition, it is also essential to check for less obvious signs to look out for early serious complications which may present in patients. So the structural evaluation of both the patient complaints and the examination is important to get an effective diagnosis and treatment. Now I would like to call Nishan Jha for
Good afternoon everyone, I am Nishan Jha, roll number 76. My topic is treatment of CSM. As my colleagues have beautifully walked you through the anatomy, pathophysiology, the diagnostic criteria, the signs and symptoms of the CSOM, now I would like to complete this clinical loop by telling you what does the doctors actually do about it. So talking about the treatment of CSM. The treatment of CSM is divided into two broad arms, the medical management and the surgical management. So, the goal of both is to create a dry and safe ear. What does that mean? So, creating a dry, safe ear means to stop the infection and prevent any further dangerous complications. And the secondly, to rehabilitate the patient's hearing. So, firstly we start with the medical management, and then we escalate to surgical management if needed. In the medical management, the first step is the oral toilet that gives the foundation of the medical management. So what is oral toilet? It is the cornerstone of the medical treatment because it is simply keeping the ear dry and safe. It is not just a cosmetic step, but it reduces the bacterial load of the ear. In this, as you can see in the image, the ENT surgeon uses a microsuction or a dry cotton moppings to physically remove the discharge, debris and keratin. And this helps the antibiotic drops to effectively act. So here as I have written, without oral toilets, the best antibiotic drop without oral toilets are also ineffective. So the antibiotic drops. The antibiotic therapy is the first drug of choice is always ciprofloxacin ear drops. So ciprofloxacin ear drops, in this I have written that avoid aminoglycosides. What are aminoglycosides? Why should we avoid them? The aminoglycosides like gentacin are never used in perforated ear cases because they can damage the hair cells and this can lead to hearing loss. So we always use ciprofloxacin and further moving to the surgical management. And as we go to the surgical management, the foremost surgery performed is myelingoplasty. The myelingoplasty is basically repair the tympanic membrane or for the perforation. For this, we have to maintain the ear dry for at least 3 months. And after that, the graft is taken. From where the graft is taken? The graft is usually taken from the temporalis fascia, which is present here. Talking about the procedure, as you can see, the first step is the anesthesia, in which we give the local or general anesthesia. After that, we go to the approach. The approach can be post-auricular approach, as you can see. In the post-auricular approach, we keep a small incision just behind the ear, which gives us the maximum exposure. And the other approach can be endoaural approach or the above the canal. So then we go to the freshening of the perforation margins. As you can see, the old edge versus the freshened edge. There we have to do the freshening of the margins to make the healing promoted. And then we go to the elevation of tympanomeatal flap. What is tympanomeatal flap? The tympanomeatal flap is the outer layer of the eardrum plus the skin of the ear. And then we go to the graft harvesting. In the graft harvesting, we take the temporalis fascia, which is the most preferred graft. And then we do the underlay graft placement. It can be overlay also and it can be underlay also. And then we give 3 to 6 weeks for the perfect recovery of the patient. After that, after myelingoplasty, we move further to the tympanoplasty. The tympanoplasty, again, the indications are same, that we require more than 3 months and there is a conductive hearing loss. How we define it? It is same as the myelingoplasty only, but the additional point is we reconstruct the ossicles also. The graft again is taken from the temporalis fascia only and we use the cartilages also. And now, defining the types of tympanoplasty, the type 1 is as same as the myelingoplasty, and the type 2 to type 4. In this, we reconstruct the ossicles, that is the ossicular reconstruction. Now I would like to play a video which shows the tympanoplasty. Here, we can see the perforated ear, and now the types of tympanoplasty. In the types, first we are saying here we can see the perforated ear, and then in the types of tympanoplasty, first we go for the approach. Here I can see that you can see that is the post-auricular approach, then there is the endaural approach, and then the transcanal approach. The transcanal approach is the least invasive, and it is the best preferred over the post-auricular approach, and this all depends on the disease extent to where the disease is spread. Now moving forward to the mastoidectomy. Before that, for the post-operative cause, for the post-operative precautions, as you know, that recovery is more crucial than the surgery. And for the recovery, the patient should avoid strenuous exercise for at least 2 weeks, and there should be avoid of water going inside the ear. And after that, we move to the mastoidectomy. It is the most comprehensive and the most extensive surgery performed in case of CS1. In this, we can see the core indications are the unsafe CS1. There is the eticoenteral type, as mentioned earlier. In the eticoenteral type, in this mastoidectomy, we can see the surgeon uses the drill, and if he drills through the mastoid bone and clears the infected ear cells. To keep it simple, imagine a honeycomb structure. In that honeycomb structure, a bad fungus has invaded it and it is spreading in the honeycomb structure. And now the surgeon will use the drill machine and clear the honeycomb structure and clear the honeycomb structure and clean the all infected air cells. Moving toward the hearing rehabilitation. As you know, after all surgeries are performed, but also after all surgeries are performed, 25 to 30% people suffers hearing loss after successful surgeries also. And for that patients, our last step is hearing rehabilitation. Hearing rehabilitation can be divided for the two options, the conventional hearing aid and the bone-anchored hearing aid. Conventional hearing aid is used for mild to moderate hearing loss, and for bone-anchored hearing aid is used in the cases where there is extensive hearing loss and the conventional hearing aids are not sufficient. As you can see, in the bone-anchored hearing aid, it bypasses the middle ear and directly transmits the sound to the cochlea via the bone. And this was my treatment part, and now I would like to call Prakash to summarize the whole case for you. Thank you.
Good afternoon. The case overview goes like this. The symptoms we have seen: persistent ear discharge, hearing losses. Clinical findings were middle ear involvement, tympanic membrane perforation, continuous discharge. Diagnosis is based on history examination and investigation, confirmed as chronic suppurative otitis media. The type was safe type. The management goes like oral hygiene, antibiotic therapy, and in severe cases surgery. Conclusion: early diagnosis is crucial. Prevent complication, hearing impairment, vasculitis. Last but not the least, as we conclude the enlightening session, it is my distinct honor to propose the vote of thanks for today's seminar. First and foremost, I would like to Head of Department, Dr. Yuvraj Bhosle sir. A very special and heartfelt thank you goes to Dr. Hannah ma'am. I also wish to thank the entire teaching and non-teaching staff of the management department. And thank you everyone for being here for your time and contributing to the success of the seminar. Thank you.
इतने सालों में फर्स्ट टाइम वोट ऑफ थैंक्स सुना है सेमिनार में।
क्या बोले?
फर्स्ट टाइम वोट ऑफ थैंक्स सुना है सेमिनार में।
वेरी गुड। पहले तो मैं हेड ऑफ डिपार्टमेंट नहीं हूँ फॉर योर टाइम, आई एम जस्ट इन चार्ज ऑफ द डिपार्टमेंट राइट नाउ एंड या so we have to begin this right now very fast, very nicely presented. कौन होता तो जब ये खेप unsafe safe CSO तो जबरदस्त प्रियंका पार्ट very nice. Everybody was good. गुणा माना होते का राइट तो हम बोला Anna Bashir has just given a Marathi exam.
I have cheated in a Marathi paper. Okay, so yeah, all of these students, my batch, all of them were awake till yesterday till 2 o'clock night. I was with them, we were on Google Meet, they were making changes. One student I want to appreciate because all of them, they had got their, topics were allotted 2-3 days before. So they were preparing from 3 days. But this one boy, yesterday 4:30, I asked this boy, can you do the internal air? Because we didn't have a side of internal air. He said yes, and he was so polite, and he was so, he was confident that he'll do it. He made the slides, he prepared. Today I saw he was not looking towards the slides. He had, memorized it, and he was saying it by his own words and everything. That was very nice of him. So all of you should be like that.